Thank you, Professor Martin, for the opportunity. And I would be discussing on decision making in squint surgery and how we can try to get the balance right in getting the eye movements and the deviation correction. So before we start the cutting procedure, it's always important that we should be careful because sometimes, as we'll see, looks can be a bit deceptive. It's been talked about by Dr. Siddharth. Refraction is the key intervention. It's always important to look at the refraction, look at the records. Sometimes age appropriate cycloplegic refraction has not been done, and you can miss a partially accommodative esotropia, or you can call a partially accommodative esotropia, which may be truly a complete accommodative esotropia. So it's very important to do an age appropriate cycloplegic refraction. Many think that it's only accommodative esotropias that have the need for refraction. It's extremely important to know that divergent squints also need a very proper refraction, although not for accommodative control, but for the quality of vision that they have. So many IDS children may just fuse if a good quality refractive correction is given to them and a good quality image forms, which helps in the fusional mechanism and the control. Always check for amblyopia before you operate. It's very important to intervene for amblyopia before any surgical intervention is done. Otherwise, the parents often lose interest, and you, of course, have wasted time, precious time, which can help in correcting a subnormal vision or a lazy eye. Always treat amblyopia appropriately. We are lucky now that a lot of interest and a lot of options are now appearing for management of amblyopia, but we always know that kids are more smarter than us. So just be careful. Always educate the parents and those who are closely associated with the child about appropriate amblyopia therapy. Often orbital lesions can present as acquired squints, or any acquired squint should always raise a red flag. This was a patient who presented with an acquired Brown syndrome because of a cysticercosis in the muscle belly, superior oblique muscle belly. So it's very important in cases of acquired strabismus to do a thorough examination, identify the cause, and manage that before you think of surgical correction of the strabismus. Always ask for and beware of variability. History of diurnal variation can easily be missed, and we have learned by burning our fingers that myasthenia gravis is the biggest mimicker and can present in any possible way. So this patient presented with an acquired elevation deficit, and it was a myasthenia that was responsible for this. Before you take your decision making, be sure of your diagnosis. Always be sure to differentiate between Duane's and sixth nerve palsy. Very frequently get children referred for sixth nerve palsy, get a lot of investigations and radio imaging done when it is a Duane's to start with. A kind of dictum I tend to follow is a congenital sixth nerve palsy is extremely rare. It's almost a Duane's unless proved otherwise. Congenital unilateral sixth nerve palsy, more likely to be a Duane's. Again, pseudoesotropia is often mothers, parents, mother-in-laws extremely worried about the child having a squint. So always be careful, repeatedly examine the child. Now with phones, ask the parents to take photographs with a flash and see for the corneal light reflex. If the light reflex is centered, even when the child is looking on the side, you know you're looking at a pseudoesotropia. But keep the child in follow-up. There is nothing that precludes pseudoesotropias from later on presenting with acquired accommodative esotropias or even infantile esotropias. The factors that affect our decision making would be angle kappa. So look at angle kappa. Look at either eye fixating at the distance to see what is the possible angle kappa. Look at adnexal relationships, epicanthal folds, hypertelorism. Look for eye movements, both versions and ductions, and for any limitations that need to be corrected intraoperatively. Therefore, FTT is a must before you take a decision. And what is your final plan? It's a cosmetic outcome or a functional outcome, whether you're planning to overcorrect or undercorrect, and of course, associated oblique overactions. Deepening procedures, the most common is a graded recession, although there are many alternatives to that. And of course, tenotomy, tenectomies for the oblique have been are very popular, not at all for the recti, and same marginal myotomies for the inferior oblique. There are limits for the maximum recession or resection you can do. So always be careful for the limits. Less than the minimum amount, it is very ineffective and you don't get much of an effect. And beyond the maximum recommended for conventional surgery, you're going to have an gross underaction that will create limitation of movement in horizontal gazes. Problems of excessive recession would be palpable aperture changes, unilateral underaction of muscles causing diplopia and that gaze of action, and decreased excursion of the globe in circadian velocities. Strengthening procedures, the most common for recti are graded resections, although advancement is possible in a previously recessed muscle. Tucking or double breasting is recommended for superior oblique, although the alternative for resection, now plications for recti muscles are also increasingly very popular for their speed and the lack of or the reduced severity of reaction, swelling, edema in the post-op period. Again, maximum limits of resection, don't go beyond the recommended, because then you are actually cutting away myofibrils, and which is weakening the muscle rather than strengthening beyond a point. There are gross nomograms for primary surgeries, and many of these nomograms have been created by expert surgeons over a long time with their experience. We use these nomograms as we start our surgical procedures, but over time you can actually see how your surgical outcomes are different from those that are recommended, and might be you might require to adjust your nomograms ever so slightly. Bilateral recessions versus unilateral resect is a long-standing discussion with really no conclusion. It's difficult to perform a bilateral recession in an adult if you have to do under local anesthesia like we usually do for adults, and therefore we prefer unilateral resect. Also the additive effect that unilateral surgery gives us. So a large angle, think in more in terms of unilateral surgery to get greater correction of the deviation. Other important points that recessions are stronger than resections. Response to the medial rectus is more in almost a 3:2 ratio to the lateral rectus. And therefore, there are again some gross ideas that per millimeter effect correction gives you the amount of prismatic correction on a surgical procedure. So we also know that if you do one eye, you get virtually 25% more effect. So an RNR procedure would give you a much more correction of deviation as compared to bimedial recessions or bilateral recessions. You get almost 25% greater effect in infants as compared to adults. And even in older children, there may be up to 10% additional effect compared to adults. Important points to remember is do not induce incompetence. In a competent squint, that's why it is important to remain within the limits of described competent surgery. Larger amounts will cause deficient ductions and palpable of aperture changes. If you have to do correct large deviations, divide the surgery between the two eyes and always be consistent. Other factors would be age, like we said, it's more effective in younger patients. Patients respond. So a previous surgery in the other eye can help you if the response was less than what was expected. You may require to slightly overdo the amount of surgery you do. Anatomical variations, previous surgery, larger deviations give you more response per millimeter recession or resection. So you may get a greater response from 6 mm recession to 7 mm recession versus 3 to 4 mm change. So it's important to remember that larger deviations can give you more response. And finally, what is the sensory state of the patient? And when you are planning surgeries, you always need to know whether you can do bilateral or you may have to do unilateral surgeries and what are your desired results. Variations per surgeon also factor in by placement of sutures, exposure of muscles, amount of dissection done. That's why two different surgeons may have an entirely different effect for the same amount of surgery done, because we are always having minor differences in the amount of dissection we do, the cutting of the check ligaments, the intermuscular septum, and particularly more so with vertical recti, where you have to be careful about the obliques that are associated with the vertical recti. There is a lot of movement towards the phonics incision, which is faster, has less bleeding, although there are no differences in outcome. But phonics incision requires a little more expertise as compared to the limbal incision. And if you are a beginner, then probably limbal incision with its clean anatomy would be far better. These are, of course, outcomes that sometimes make a difference in amount of your decision. So like intermittent exos, we sometimes in adults want to overcorrect mildly so that we can catch the exotropic drift that these patients have. But then, of course, that is on a case-to-case basis. Always measure A and B patterns, because you need to be able to correct for oblique overactions. And if there are no oblique overactions, you need to shift the recti so that the A and B patterns can be corrected. Botulinum toxin for early rehabilitation is a very good idea, particularly for 6 nerve palsies, where you can get very good outcomes in the post-op period. The eye to be operated, sometimes the patient might feel you're doing the wrong eye, but just like in a case of third nerve with aberrant innervation, you can see that there is a lid elevation on adduction, which can be used if you operate the other eye. Same eye surgery would not get you that lid elevation because of the fixation duress kind of effect that the other eye surgery would have, and you can correct the ptosis along with the third nerve. Importance of eye movements is there because you need to decide whether there is any limitation of movement that needs to be corrected. So this was a case of post-orbitotomy, partially recovered 6 nerve palsy. You can see good movements have recovered. We did a large R&R procedure and you got good results. However, if there is limitation of movement, like in this case of a 6 nerve palsy, you can see that the abduction is almost not there. A severe abduction deficit, no amount of resect procedure is going to give you good results. So a transposition procedure was necessary. We did an adjustable MR recession along with a half muscle with vertical recti transpositions. So basically, when you are deciding to operate, although things can be confusing, there is no alternative to a good workup, correct diagnosis, and realistic expectations, because it's always important to be prepared for the complicated and difficult post-op questions that the patient may have. Thank you very much for the opportunity.